I'm Jill Thornton, I'm Head of Programme here at Better Start Bradford. It's Baby Week, as you can see from our backgrounds. It's always an exciting week. We always have exciting and interesting and really important things happening during Baby Week, and it's our opportunity to highlight how important babies are in our lives and how important life is for our babies, and that we look after them and we do all the things that they need us to do during the first part of their lives. And that's what Better Start Bradford is all about. And so we try to explore things that are relevant to our programme, but also that help us to take our thinking and our work forward. And I'm going to talk a little bit about our work later on. But before I speak, we're going to hear from other, probably much more interesting speakers who are going to talk to us about inequalities in maternity services and maternity health care. And the reason we decided to do this is because it's been a really interesting and challenging year for everybody. And it's brought to the forefront all sorts of issues that we face in terms of inequalities in our society and how that impacts on people in every form, every part of their lives, but also especially this year in healthcare. And our event today, our webinar today, was triggered when I read the Babies in Lockdown report, which Agnes is going to reference later on. And the thing that struck me most about that was how much it highlighted some of the inequalities that our parents are facing and our babies face. And it also pointed us in the direction of the 5 Times More campaign. And our programme's been going for quite a long time now. We've got lots of real expertise in maternity and early babyhood. And I didn't know about the 5 Times More campaign. And I kind of felt sort of embarrassed and uncomfortable about that. And felt that we needed to know more about it and to think about what that meant for us in our programme, but much more widely for how we can influence, understand and think about how maternity services are provided and the unequal impact or the impact of inequalities on the people who are receiving those services. So Chloe's going to tell us a little bit more about that when she speaks. But I think we've seen a year of immense change for us in our programme. So we would have been doing this live, and we've learned how to do it virtually, and we've learned how to still reach our parents in a virtual world. But we're looking forward to going back to meeting them face to face. This is a political issue, and I think we shouldn't shy away from that the inequalities that are faced by Black people, by people from South Asian communities and other minority ethnic groups are as a result of racism. And we need to understand that and think about how we deal with that. And we know that all our services have lots of people within them who are good and kind and well-meaning people who want to do the best and who want to help people to get the best out of our health services. But we have to look under the cover and see what happens for real people in real experiences. So that's what today's about, and hopefully we'll come away from it thinking more about what we can do to make things better and to spotlight where things are going wrong and really address them. So that's my ambition for today. I do want to finish off with something that is really political, and I will try not to get emotional, but I probably won't. But it's been a really tough couple of weeks with all the elections. I had my fingers in my ears for most of the American election. But I think Kamala Harris being elected to Vice President of the US is an enormous thing to celebrate. I'm celebrating it, and I'm sure that many other people are. And I hope it's taken both the US and us a step forward, because although we think what happens in the US is different to what happens here, it isn't really. And we have our own issues to tackle here. But I'm hoping that we can celebrate just briefly that massive, enormous and important step forward. So please enjoy today, take part, give us your feedback, and listen to our amazing speakers. I'm just going to talk, just briefly introduce the speakers. So we've got Clotilde Abbott, who I think is known as Chloe, and she's going to tell us about the 5 Times More campaign. The campaign that's been set up to highlight and to seek to address the stark and terrifying fact that Black women are 5 times more likely to die in childbirth than white women. And something that, you know, when we think about it, it's almost, you can't believe it, but we need to hear about it and to understand it. We've got Ghazala Mir, Dr. Ghazala Mir from Leeds University. And I met Ghazala a few weeks ago on another event, and Ghazala's work exploring inequalities in services and talking about how we achieve equity in public services is so important and goes alongside the other discussions we're having. And then we've got Agnes Ejipong from Best Beginnings, who's going to tell us a little bit more about what the Babies in Lockdown report has highlighted. So I'm really looking forward to hearing from them. I think their presentations are going to give us such a lot of information and such a lot of food for thought. So welcome, thank you for attending, and please enjoy the event.
Good morning all. So I'm Clotilde Rebecca Abbey, but most people know me as Chloe. So today I will be talking to you a little bit about 5 Times More, how we came about, the work that we have done and what we hope to get out of the campaign. So I'm Clotilde, I'm a mum of 2 boys. Outside of 5 Times More, I run a social enterprise called Prosperities. It's a maternal wellbeing social enterprise that supports Black and South Asian mums in Southwark and Lambeth, but due to COVID, now I'm supporting women all over the UK because it's virtual support. Aside from that, I'm the MVP co-chair, so the Maternal Voice Partnership co-chair for Lambeth and St Thomas. I help co-design maternity services in Lambeth and Southwark. So I'm going to start my presentation. So 5 Times More, addressing Black maternal disparities in the UK. So I'm not sure if you're aware of, Black women in the UK are 5 times more likely to die during pregnancy, childbirth, and 6 weeks after the period compared to white women. And this was stated in an Embrace report in 2018. But one thing I must say, it is relatively safe to give birth in the UK. Maternal mortality occurs in fewer than 1 in 10,000 pregnancies. What is 5 Times More? So 5 Times More is a registered social enterprise that campaigns to highlight the disparities in maternal outcomes for Black women in the UK. So how we started, Tanuke at the time approached me in 2019 with this idea. She saw the Embrace report. We both saw the Embrace report because we all work with pregnant mums, and she was not happy with it. She runs Mums and Tea, which supports Black mums by holding fun events for mothers. And half of the mums that she spoke to all had the same experience that she had. So during her first pregnancy, she had an awful experience. She wasn't listened to. She was diagnosed with preeclampsia very, very late into her pregnancy. And to her, it just wasn't a pleasant experience. So because of that, she approached me and was like, you know, all these mums are saying these things, it all echoes in my pregnancy. Let's join up together and see what we can do. At the time, it wasn't called 5 Times More. We actually didn't have a name for it. We were just going to do an event in the summer 2019, just to talk about 5 Times More. But we end up doing something much more bigger, which I'm so happy we did. So what do? We empower women. So we empower women by giving them our 6 steps. So we made 6 recommended steps for women to use while they are pregnant. And I'll go through the steps now. The first one is speak up. If you feel like something isn't right, just make sure you speak to your health professional, your midwife, the doctor, your GP. Don't stay silent. The second one is find an advocate. We try to empower women to advocate for themselves, but just in case they can't advocate for themselves, we ask them to find an advocate, someone who can advocate for them when they are in a very vulnerable state or they're not able to speak up for themselves. And we ask them to find someone that they can trust, or family member or their birth partner. Number 3 is seek a second opinion. This was the one that a lot of women didn't know. They didn't know they were allowed to seek a second opinion. A lot of women assume if the midwife or the doctor says, this is what it is, it must be true. But it's all about telling them about their birth rights and, what they're allowed to do, what they're not allowed to do. Number 4 is trust your gut. If you feel like something isn't right, make sure you speak up about it. It's your body, you know best, you know your body, so make sure you speak up. Number 5 is do your research. So we tell women to do their research, but on trusted websites like nhs.com, niceorg.com, or patient info. And the 6th step, which we added not so long ago, is document. Make sure you document everything, as it's so important, just for reference for you to go back, just in case anything happens, it's there. Sometimes you go to your midwife appointment and you kind of forget what the midwife told you. It's all there in terms of what painkillers you're given, what medication you're given. It's just the evidence is all there. So that's our 6 steps that we use to empower women. Also, we partnered up with the Positive Birth Company. So every month, the Positive Birth Company offers Black women through 5 times more free access to their digital care package, which is all about, hypnobirthing, how to give birth, how to breathe, what to expect. So that's what we do for Empower Women. Educate as well. So we try to educate women, but also health professionals. So in October, well, actually in September, we partnered up with the RCOG, the Royal College of Obs and Gynae, and we co-produced 6 steps for health professionals, which we launched on the 2nd October, and that got a lot of coverage. So I'm going to briefly go through this. The 5 steps that we done with the health professionals. Number 1 was listen, and it was listen to the woman. And a lot of Black women complain about not being listened to. So we just know that if she's raising a voice or she's coming across aggressive, that's not her. She just wants to be listened. Number 2, remove any barriers to communication. So this talks about, having a translator, using language lines, also looking at the woman's body language, what's the body language saying? Check that you are providing clear information. And this was the one that hit home to me, because I remember when I was pregnant, the midwife would tell me something and I would just agree, but I didn't quite understand, but I felt too ashamed to kind of say, sorry, I don't get it, I don't understand. So what we said is, make sure the woman understands the information you have given to her. So recap the information to the woman, or politely ask the woman to recap the information to you. It's not rude. It's just so you know that she really, really understands. Number 4, is provide documentation. So we ask everyone to document. So we ask the mothers to make sure, health professionals document, but we also ask health professionals to document just for their own reference, and to cover their own back just in case anything does happen. And number 5, which is the best one, be a champion. Be a champion for that woman. That woman is relying on you, is putting all trust on you. Be her champion. And then what we do is want to amplify Black women's voices. We want Black women's voices to be heard and their experience to be heard, and we want to learn from their experience. So we do a blog, and we don't just ask women to to post about their bad experience and talk about the bad experience. We also ask them to talk about the good experience, what went well, and how can we improve. How can we compare the bad and the good to improve on maternal services. We raise awareness, so we started the hashtag 5 times more selfie, where you put your hands in your face and you don't smile. You kind of have a serious face to say stop, but at the same time it's saying 5 times more. So just like the picture you can see. and lobby. So we did a petition in March, early this year, and it's got over 180,000 signature. Oh, sorry, not March, back in April, and it's got over 187 signatures. On our website, we also have a draft template that we ask women and just people actually in general to write to their MPs about the campaign. We submitted an inquiry to the Health and Social Care Selected Committee. So 415 women participated in our survey, which is it's a really nice number actually. So when we asked women about vaginal birth, so we asked how many women, how many of you were informed about vaginal birth? So then we asked women, you know, about home birth, water birth, C-section, and assisted birth. So home birth, 78% of Black women did not receive advice or guidance to make an informed decision on whether they wanted this, which 78% is such a high number. Same thing with water birth, 70% of Black women, so these questions were all asked to Black women, did not receive advice and guidance to make an informed decision. Also, when it came to water birth, C-section, 73% of Black women were not presented with option or potential intervention and did not receive advice and guidance to make an informed decision. And assisted birth, which is 85%. Same thing, they were not given advice or guidance about having assisted birth. And to be honest, they weren't in the right position even to consider assisted birth. So from my own experience, my second pregnancy, I had an assisted birth. I had a forceps, had no clue what a forceps was. I was told I was going to have a forceps. I went along with it because I was never told about it. In all my appointments, I was told about, I wanted to have a water birth. I wasn't high risk. So that was it for me. I wasn't told about anything else apart from that. So we asked women if they were confident in their midwife and the maternity staff that they were engaged with and are, because some of them were still pregnant. And this is kind of like a good sign. 67% said they were confident, which is a nice number, but sadly 33% were not confident, and that needs to change. You know, women need to feel confident in giving birth. As Black women, I should say, need to feel confident. And then we asked about the healthcare safety investigation branch, and 94% were unaware of the healthcare safety investigation branch. And only 6% were aware of it. And then we asked 6% that were aware of it, did you receive a follow-up? 74% said they did not receive a follow-up, compared to 26% who said they did receive a follow-up. So what have we achieved so far? So we are part of the Royal College of Obstetricians and Gynae Racial Task Force, and the Racial Task Force was built to change the disparities in Black women's health. So it's designed in 3 categories. One of them is to look at the medical curriculum. One of them is to look at women's experience. And another is to see how they can better train midwife and health professionals. And so now we are a member of that. Like I said before, we partnered up with the Positive Birth Company to offer Black women 100 digital package a month. The 6 recommendation steps that we made for the women, the 5 recommended steps for the health professionals, are successful, 5 times more selfie, and the petition. We actually, during our awareness week, which I will go on talk about on the next slide, we made 5 steps with birth partners. And I'm going to go through some the 5 steps with you. So be active. So that was the first step. Keep your partner comfortable and well hydrated. Be present in the moment and be on hand to provide emotional support. You know, number 2 was be her advocate. Your partner may not be able to speak for herself. So make sure you have that discussion with your partner and are aware of what your partner wants, if she's not able to speak for herself. Also, if a professional intervenes, ask a reason why and clearly communicate this to your partner, so then you're both able to make addition, and do not be afraid or feel afraid to ask question and document. We ask partners to do their research as well. It's helpful if you both do your research. It's not just up to the person giving birth and the woman giving birth to do your research. It's also nice that her partner does the research as well. Be prepared and be flexible. Pregnancy does not always go to plan. So be prepared for, things that may occur that was not supposed to happen. And then we ask partners to look after yourself, because if you can't look after yourself, you can't look after the woman. So that was the 6 steps that we actually co-designed with partners. So we had a few Black dads that we did it with, and they helped us do this. So we've been featured in British Vogue, Guardian, HuffPost, ITV News. Recently, I was on Harvard Medical University doing a presentation on 5 times more, which was amazing. The MP letter writing campaign, which I spoke about, writing a letter to your local MP. Since 2019, we ran events with over 700 participants, and we support over 600 women with our free hypnobirthing and advice. Okay, so in September, we launched the UK's first Black Maternal Health Awareness Week, which was a big success, I must say. We had different themes every day, and we just wanted to amplify Black women's voices, really allow Black women to have a space to talk about their experience, like I said before, good and bad. We had an online event with health professionals and mothers, and some of the key takeaways from the health professional events was we need to address Black women's health issues in the UK. So have some sort of Black women research studies happening in the UK. We realised that we can't pinpoint the statistics to one thing. It's multiple factors. And then the history of Black medicine needs to be taught. We launched our official bid for public fundraising. Also, let me mention the mums also. So what we took away from the mums panel was dignity, respect, compassion, and listening on fundamental requirements that are clearly missing when administering care to Black women. And then we launched our official bid for public funding, public fundraising, because me and Tanika have been doing this for over a year now. We do a lot of events, but we're not getting nothing from it. So we need to fundraise to be able to carry on the good work that we're doing, but also to amplify Black women's voices. So when Black women share their stories with us, we do make sure we give them something in return. And we also make sure that they get, we signpost them to the correct support, because some of these stories are very traumatic and some of them are still living with it. So we signpost them to correct health professionals and make sure we pay for it so then they can get the relevant help. So we support 2 other campaigns. One is the Delissa Park Foundation, who Delissa Park died 5 years ago now during pregnancy in Lewisham, so in southeast London, a hospital, and her daughter was born practically brain dead, so she can't walk, she can't talk, she can't eat for herself, and Delissa never got to see her daughter, and her daughter never even got to see her mother. And then, so that's the Delissa Parks Foundation. And then we support Beyond Strength, which talks about Shamika's story, who is a young mum, gave birth, and she had retained placenta. Only on day 11, she got the relevant support. So she kept going back and forth to the hospital, and they told her that she had a mental health illness. I think it was depression and anxiety. And that's what they put it down to, not knowing that it was retained placenta. And with Shamika, why she was so lucky is she found that inner strength to carry on going to the hospital, because she knew her body and she knew something was wrong. But if she didn't know that, and if she didn't have that strength to keep going, I don't think Shamika will be here today. So we support both of their organisations. But also what we want to do is we want more information, we want more statistics for mums. But so far, all you hear is that mortality, but what about mobility? What about the near misses? What about women who are, have a child and the child is brain dead because of lack of support they had or not being listened, or women who are chronically ill, because Shamika now is chronically ill. She's in and out of hospital every day and always in pain. So what do we want to do? We really want to close the gap. We want to close the gap with the statistics. We need the statistics of Black women to go down. We want people to stop using the word BAME. We are Black women. Black women are dying. Don't be afraid to say Black women. Saying BAME and putting us all in one category is so damaging and dangerous to us all. We want to look at like I said before, the near misses and, hear about women's experiences. And we need medical curriculum to change. Medical staff should be taught the Embrace report. During the health week, when I was speaking to the health professionals, there was two midwives, one a student midwife who just finished her third year, and one a midwife. I asked the student midwife, was you taught about these statistics? And she said in her first year, there was one slide that spoke about Black women. That's not good enough. They need to be taught about this every year, and it needs to be more than one slide. How can you support us? Well, you can take a selfie, write to a local MP, donate if you're able to, but just keep spreading the word and spreading the awareness. And that's it for me. Thank you.
That was incredibly powerful and had sort of major important messages to listen to. I think there's some interesting and really relevant things that we can take away from that, but I think fundamentally the main thing is about supporting the campaign and trying to work with you and with the Black women in our own area to achieve the change. And I think some of the things that you said are really hard hitting. In a way, it doesn't matter if there have been no deaths locally recently and that the number of deaths are small. That is true, and it's something to be very grateful for that we live in this country. But having such a huge disparity isn't something to be grateful for, and it is something that we need to address. And so it's absolutely right that we should be looking at it. So thank you so much for describing the campaign and for the amazing work you've done to build the campaign so quickly and such a strong and effective campaign so quickly is testament to the strong feeling, the absolute validity of the campaign, and also your amazing commitment to it, you and your colleagues. So thank you so much. So I want to move on to Dr. Ghazala Mir, and she's going to be joined by her colleague Rizvana Hassan, who will be talking to us about how inequalities emerge and how they work within public systems and within services, and what are the things that we can learn from research that will help us to show where that's happening, to understand where it's happening, but how to do things differently in order to reduce those inequalities and those discriminations that occur in our services. So I'm going to pass over to Ghazala Mir now, and welcome, Ghazala. Really looking forward to what you've got to say. So thanks very much.
Thank you very much. I'll just share my slides. Okay, so I'm going to be presenting with Rizwana, who's a member of the HOPE group, which was a group of bereaved women who was set up as part of our research project. And the research covered women in Leeds and Bradford. So just to give you a bit of background, this is the most up-to-date kind of release of Office of National Statistics figures about infant mortality. That's the death of a child born alive in the first year of life. And you can see here, I won't call them disparities or inequalities, these are inequities, because as somebody mentioned in the chat, a lot of this is avoidable, for avoidable reasons. There are higher rates. And we can see again, Black mothers having much higher rates of infant mortality 2.5 times higher in Caribbean mothers, nearly twice as high in West African mothers. Pakistani mothers also nearly twice as high. And teenage mothers was another group that we included in our research. And what really every year, what I see that the Office of National Statistics does is say the highest rates of infant death are amongst teenage mothers. And that is actually not true. The highest rates are amongst minority ethnic mothers, and we really need to be aware of that, and to make sure that these are centre stage in terms of addressing health inequalities. And this affects not just women who are born abroad, but there's other research to show that mothers from ethnic minorities who are born in the UK actually have higher rates of infant death. And the research that we have, and it's difficult to find policy documents that actually acknowledge this, like, some old policy documents, but environmental stresses are a huge reason, as Chloe mentioned earlier. Improving services and increasing social support for women at risk are all issues that need to be taken account in interventions to try and address these inequities. And the risk of dying in pregnancy, as we've heard in the previous presentation, is 5 times higher amongst Black women. Amongst women of mixed ethnicity, it's 3 times higher. Amongst Asian women, and I agree that we need to break down these broad categories. BAME and BME are too broad. Even amongst Asian women, we really need to be looking at the different sort of categories within that, because there can be different issues affecting women within that group. But poverty is a huge issue across all groups, and nearly a quarter of women who died from who had maternal mortality were born outside the UK. 42% not being UK citizens. So migration status is also a huge issue. Now, how do we understand these? I've talked about inequities, and often what we hear about is the issues that are apparent at the individual level, people not having understanding of the system, not getting information, not being able to access information, being mistrustful, fearful of services, having lower health literacy, lower capacity, more deprived networks in terms of who they can actually get support from. But I think the way to understand these, I've put inequalities there, I would say inequities really, is that there are much bigger forces at play than the individual or the communities in which the individual actually lives. There are organizational practices that are influenced by the socioeconomic and political context. And as Jill mentioned right at the beginning, these are political issues. We're located in societies in which politics play a huge part in terms of competition for resources, where resources are allocated. Some social groups having much more power to influence the allocation of resources. And issues like racism, stereotypes, misconceptions. We're constantly hearing about consanguinity as the reason that Pakistani mothers are experiencing higher rates of infant mortality. Again, constantly looking at the individual level, but actually, there's a lot of evidence that show congenital anomalies are also linked to deprivation, and congenital anomalies affect all ethnic groups. They're not just specific to one particular group. And where there may be community level issues, there are lots of other things that are going on, poverty being a huge factor. And these socioeconomic and political kind of this context actually influences how institutions deliver their care as well. So they can be failure to recognise or meet needs, poorer quality service. If you look at the representation of staff, are they actually representing the communities that they're serving? Certainly that is not the case really in many areas, including maternity services. You don't get the community that is being served represented amongst the staff. And that leads to barriers to service provision, not understanding racism and stereotyping being apparent within institutional practice as well. And all that leads to inequities in service and outcome. So when we're looking at the interventions to address all these issues, we have to look at these 3 different levels. We can't just focus everything at the individual level, at kind of a deficit model of what women haven't got that we need to then try and improve in the individual women or their communities. We've got to look at how can we meet institutional needs as well, and look at the political and social context. And from a review that we did that was published by the United Nations, we identified a number of different strategies that I can't really go into in a lot of detail, but just to show you at the macro level what kind of issues can help in terms of the evidence base, and at the institutional practice, representation amongst staff being a key issue, reducing discretion where bias can creep in, and at the individual and community level, then a lot of the things that we do see in this area. Okay, so just to say a little bit about the quality of healthcare, we know that it's more likely for women from minority ethnic groups to be left alone during labour, to have later booking in terms of maternity care, to be less aware, as the previous speaker also mentioned, about the choices around maternity care, to have less trust and confidence in staff, and that there are lots of communications and skill gaps, and training leaves a lot to be desired. The research that we did looked at the networks of support that women had, and this was a bereaved Pakistani mother talking about the kind of support that she had. And you can see there's a huge reliance on healthcare professionals within this network. So the mother herself is not represented here. You can see her family and friends in one area, and then on the right there, the health professionals completely disconnected from what was going on at in primary care. Compare that with this network of support for an adult white British non-bereaved mother who felt she had had good support during her pregnancy. And you can see that it's a completely different network. We've got lots of mother and baby groups, baby cafe, net mums, the health visitor actually being connected via her friend to the other part of the network, and then a lot of other support, that the single sort of dots on the left there, showing other ways that this person was supported. And that is the kind of network that we need to be trying to get for women from all ethnic groups. This is what good support looks like and what leads to good outcomes. So our research looked at this from a participatory point of view. We tried to model what we thought should happen within maternity services and healthcare that was relevant. So trying to make the research relevant to women who had experienced an infant death. We wanted to make sure it contributed to change in the system. We wanted to make sure that women felt empowered by the research process, and to take an ethical approach to co-produce knowledge. And this is what we're really suggesting that services also need to do. So I'm going to pass over next to Rizwana, who's going to talk about her experience of experiencing an infant death, and also her experience of being involved in the research. So over to you, Rizwana.
Hello, I'm just going to tell you a little bit about myself so you can get a little bit of a picture of who I am. I'm a primary school teacher by profession. I'm happily married, and I'm a mother of 5 children. We lost 2 of our sons as babies, and we're blessed to have 2 healthy boys and a girl in this world. And my experiences of loss and my journeys in hospitals is what made me who I am today. Now, I am a British Pakistani, and I have first-hand experience in some of the inequalities faced by my community, which have been mentioned in the previous 2 colleagues. Now, I'm going to start off by saying I am grateful to the NHS for everything that they do, but through my journeys of hospitals, I noticed that being listened to is a key factor, but it isn't actually implemented. Now, I lost 2 sons, Hashim when he was 2 months and Heather Ali when he was 5.5 months. Now, my planned cesarean section for Heather was on the date that my son Hashim's death anniversary was. Now, I explained this to the consultant, how can I celebrate one son's birthday on the day of my other son's death anniversary? And I pleaded my case, and they listened, and they turned around and said that I have to have the cesarean on that day. They couldn't even give me the benefit of doubt of doing it a day earlier or doing it a day later. You've all heard this saying, don't judge a book by its cover. And it's common, we all say that, but sometimes we do it without even realizing. And through my journeys of hospitals, I often felt that I was judged by my appearance, and I was talked at rather than talked to. And for some reason, wearing a hijab or a headscarf meant that I didn't understand English, and nurses would the volume up when speaking to me. Their tone would change when they were talking to me. And if they'd have taken me at face value, they would have known that English was my first language and it wasn't an issue in any way. And having my husband beside me, another stereotypical image, because he had a beard, he's a practicing Muslim, I'm a practicing Muslim. My headscarf and his beard meant that I wasn't able to understand or speak for myself. And often I had people looking at him when they were talking to me. And that really, really upset me, because it was hard enough being in hospitals, going through what I was going, and these things could have been avoided. Now, being a part of Hope gave me the chance to have my voice heard, and that voice isn't just for me. Alhamdulillah, I'm blessed. I can speak the language. I've got friends, family, a good network of support around me. I often used to sit with my children in hospital and listen to the way that other doctors and nurses spoke to parents that couldn't speak the language or couldn't voice their concerns. So when I was presented with this opportunity with Hope, it gave me a chance to have my voice and the voice of our community heard. And as you can see, I've taken part in a few things over time. And even now, every time I'm offered an opportunity to share some of my experience, as emotional as it is and as hard as it is to live through those stories again and again, I live with the hope that it will change some things for some of those parents. It's exactly those same things that the speakers have said before. We think that being listened to and taken seriously is an important aspect of hospital journeys. In writing, in black and white, that is absolutely true. But when it comes to the reality of it, it's not there. Now, the empathy side of it, feeling understood emotionally and being given that support, I, for one, can say I didn't get that. I still to this day don't understand why a date in a planned cesarean could not be changed to a day earlier or a day later. I didn't know at the time, but then my baby boy that I gave birth to on the day of my son's death anniversary also died. How I get through that day every year and how my family gets through that, only we know.
Are you all right, Rizwana? Would you like me to take over?
Please, if you don't mind.
Okay, yeah, of course, yeah. And I think, you know, Rizwana's experience is much more recent than some of the other women in the group. And I can speak for myself as also having experienced an infant death many, many years ago. It's something that never actually ever leaves you. I felt that my experience was enough in the past for me to actually do this piece of research, but the kind of feelings it brought back for me were really so powerful. And Rizwana and other women in the Hope group have very bravely kind of come forward and spoken about their experience for the sake of other women and to make health professionals just realize the impact that this has that never actually ever leaves. So this slide is actually about research across the whole group of women. Similar to the previous speaker, they were asking for all the things that Rizwana has been through, but also being encouraged, reassured to have respect and dignity, not to feel lonely or isolated. And women who had a bereavement said they often got no bereavement support at all. And that was a key thing for them that they needed to see happen. From the research, we found that many professionals really were focused on what was happening outside of healthcare services, focusing on the women or the communities, or focusing on things like a socioeconomic position, as though it had nothing to do with what they did within healthcare services. So a review of deaths within one institution it concluded that, you know, all the factors were nothing to do with what was happening within the hospital itself, a much wider problem of social economic support out there. So this sort of language of in here and out there being two different unconnected kind of arenas. And partly the reason they could come to that conclusion is that women themselves were not being listened to. Their concerns about how to develop services were not part of the mechanism for looking at that. And in each individual death as well, the parents' views about causation were not explored at either site that we looked at. As Rizwana mentioned, there was a general theme at the time, stereotypes and assumptions that South Asian women needed rescuing from their male partners, that they were seen as being more sexist than other men. And senior clinicians assuming, without actually directly speaking to women, that husbands were controlling through their so-called instinct, their antenna, their suspicions, which of course is another word for bias and assumptions. So in terms of what women thought were the priorities in terms of service development, targeting support for women at most risk, identifying women who were less likely to have the kind of support they needed in place, representation amongst different ethnic staff from different ethnic backgrounds, including women in decisions about how to run services, not having policy decisions that didn't actually include women with direct experience of infant mortality. Having better language provision and professionals actually keeping in touch with each other so that there wasn't this disconnect between different parts of the service. So just a few resources there. The key, there's links in the slide if these are going to be distributed. We had a key findings report from the research that talks more about the networks, the social networks, the systematic review that I mentioned. And we've also done a YouTube video, which is from the international work that I've been doing on how to improve public services for ethnic and religious minorities, that just talks about the whole issue in a accessible way. Thank you.
Thank you, Ghazala, and particularly thank you, Rizwana. That was so hard for you, and I completely understand how difficult it is to go through all that again. But I think that what I'd like to say, and I'm sure lots of people would echo, is thank you so much for coming and doing it. It's so important that we hear those stories, and you and Chloe and her colleagues have experienced incredibly challenging and incredibly tragic situations. So taking that experience forward to try to change things for other women and for other families, and that just is so strong and so powerful, and I'm really grateful to you for doing that. Thank you to you, Ghazala, because I think what we've got from you is exactly what we were looking for, really, which is some thoughts about how we can change things, and that's what we want to do, and that's why we're all here. So, but with that backed up with Rizwana's own personal private experience, which it's always so important to the message to understand what it means for individuals and for people who are in that system. But you're absolutely right. It isn't about always pinning it on some characteristic that you've got, but it's about what happens in the system and how you receive those services and how you're treated in those services that matters, and that we're trying to explore. So thank you so much, and much love to you, Rizwana, for your sharing your experience so powerfully. It's had an enormous impact on the people who are here. And I'd like to move on. We are running behind a little bit, but it's all just so interesting and so powerful. But we're moving on now to Agnes Ejipong, who's going to talk to us about the Babies in Lockdown report and what that's told us about women's experience. Not just in lockdown, but the experience of the unequal experience of the COVID time that we've just all been living through, and this is really what's triggered this event today. So thanks so much, Agnes, for doing this and for being with us today to tell us a little bit more about this piece of work. Right. Welcome.
Well, firstly, I just want to say thank you so much for having me. Rizwana, I'm just so moved by your story. I'm so sorry to hear about your experience, and just thank you so much for your bravery. I think I need to just start off there, and for sharing your story, because it is just so important for medical staff in particular to hear the experiences from women and to see the humanity. I had my own bad experiences within maternity care, which actually led me to becoming the Maternity Voices Partnership co-chair alongside Chloe at St. Thomas Hospital. So I really relate to that experience and that feeling of just not being seen, and how that can change the whole trajectory of your life. And it's what's led me to even be working at Best Beginnings and the work that I now do within maternity care. So I just thought I had to make sure that I said that. So my name is Agnes Ejipong. I am the head of engagement at Best Beginnings. As I just mentioned there, I'm also the Maternity Voices Partnership Co-Chair at Guy's and St Thomas Hospital, alongside Chloe, who you've heard from earlier. My personal life, I'm a mum of 3. My youngest is 2. I have a 3-year-old and a recently turned 8-year-old. I'm a school governor with a particular focus on early years. I'm also a Health Watch Solution Committee member. I'm the founder of an awards called the Glow Mama Awards, which is all about celebrating the glow up of mums after having a baby. And I recently published a popular article which kind of links in with this presentation today for the National Institute of Health Research, discussing why Black women are not engaging in maternal health research and perinatal mental health research, and what can be done to change this. Because I think, you know, a lot of the issues that we're talking about today, it ties into why there's also a lack of engagement within the medical world. So in this presentation, I will be giving an overview. I'll be talking about the Babies in Lockdown report. We'll be looking at the impact of COVID-19 on babies, the impact of COVID-19 on parents, the impact of COVID-19 on care services and support, and then a call to action, our policy proposals and the ways and suggestions and ways forward. So overview of Babies in Lockdown report. So the Babies in Lockdown report was a joint, was a collaboration between Best Beginnings, Home Start and the Parent Infant Foundation. It was an online survey which was live between the 29th of April and the 3rd of June. So this was really at the kind of height of the first lockdown. And our survey respondents totaled over 5,000. So headline findings. So COVID-19 has had, what we found during that period of time was that COVID-19 had affected parents, babies and services that support them in a diverse way, that families that were already at risk of poorer outcomes have suffered the most, and that this pandemic is going to cast a long shadow. So the impact of COVID-19 on babies. So almost 7 in 10 parents felt the changes brought about by COVID-19 were affecting their unborn baby, their baby, or their young child. A third of respondents believe that their baby's interaction with them had changed during the lockdown period. And 1/4 of parents reported concern about their relationship with their baby. And 1/3 of these would like to get help with this. So when we're looking at that term of would like to get help, what we're looking at is parents that want to get the help, but potentially they're not able to actually access that help. Almost half of parents reported that their babies had become more clingy, and 1/4 reported that their babies were crying more than usual. Now, this lockdown has been a little bit different in regards to children, nursery age children being allowed to go to school during this lockdown. But what we saw at the first lockdown was that kind of total breakdown, that total closure of services. And even now, I'm a mum with a 2-year-old, so he's just turned 2. And one thing that is completely different this time around in regards to my other children is there's no, play and stay and baby groups and so forth. And I really feel personally that is having an impact because he's not able to do the things that my other children would do. And I know that a lot of parents, yes, we're looking at the stats, but behind that, they're real stories, and, parents are really finding it challenging to be able to engage. And even when we're looking at pregnant women and so forth, that kind of community support in regards to going to some of these groups and support networks and being able to engage with other parents and speak about your stories. A lot of pregnant women are feeling really isolated because they feel like they don't have that anymore. 6 in 10 parents shared significant concerns about their mental health, and 1/4 of pregnant respondents citing mental health as a main concern said they would like help with this, rising to almost 1/3 of those with the babies. But only around 3 in 10 were confident that they could find help for their mental health if they needed it. So we really need to be looking at that kind of perinatal mental health support for pregnant women and mums. Almost 9 in 10 parents were more anxious as a result of COVID-19 and the lockdown. And there was a notable variation amongst respondents who reported feeling a lot more anxious. So we're talking about white women, 42%, Black British, 46%, Asian and Asian British, 50%, parents 25 years old or under, 54%, and as well as parents with a household income of less than 16K at 55%. So 2/3 of parents said their ability to cope with their pregnancy or baby has been impacted by COVID-19. The percentage of all respondents that reported their ability to cope was affected a lot, was 16%, and this figure was significantly higher again amongst Asian and Asian British respondents at 26%. Nearly half of NHS social care or other healthcare staff who are pregnant or have young children are concerned about staying safe at work. And when I say are, this is in regards to the first lockdown. They told us that they feel let down and unprotected in the workplace. And those from Black, Asian and minority ethnic backgrounds felt this especially acutely. And I do want to add that, you know, some expectant and new mums, they did find a silver lining during that time. You know, some expectant mums and new mums, you know, felt that they could spend a lot more time with their partners, and that, you know, their partners could really bond with the baby. So there was a silver lining, but again, that was not equal across the board, and in particular with those that were already marginalized within the community, these structural inequalities were already amplified. So here's a quote from one of our respondents. I plan to enroll my 15-month-old in March to a nursery to help him with his social skills. He does not say words and is not responding to his name, which worries me. Now this is not possible. I suspect his development is possibly behind, but can do nothing about it at the moment. My 4-month-old has only seen his brother, father, and my face. I'm worried about his development also. I plan to take him to various classes, meet other mums with babies. This is also not possible at the moment. From an NHS healthcare professional. I'm a frontline NHS healthcare professional. Our guidance has been completely different to non-NHS. I was expected to be patient-facing, including seeing COVID patients, until a petition was sent and the guidance was eventually changed weeks later. Yet, if you were pregnant and in other professions, you'd been working from home. It's funny how this seemed to fit with worries about staffing. The skeptics would suggest the NHS couldn't afford to lose a load of pregnant healthcare workers. We're not more immune because we work for the NHS. So the impact of COVID, and we're looking now in the antenatal period. So nearly 4 in 10 pregnant respondents were concerned about getting reliable pregnancy information and advice. And this perceived access to information appears to be a core part of managing anxiety. I think we all probably can relate at the beginning of this pandemic. There was so much misinformation and information going around via WhatsApp and all different platforms. I know from my own personal experience, my mum was tuned in and I used to have to tell her that, you know, WhatsApp is not a university, so not everything that's on there is right and is correct. But you can imagine being pregnant during that time and all this information being passed around. So one of the things that we really need to be looking at is what information are we putting out and how are we communicating that this information is available so that our mums can come to us and know that actually this is our version of the truth, this is the truth, and this is where you can get that information so that they're not sucked into all the misinformation that also has gone around. Comparatively fewer British Asian and Black British respondents felt they had the information they needed during pregnancy or birth compared to white respondents. Black British respondents were less likely to have access to information and support via the web or app. So again, how are we communicating? I think this all boils down to communication. How are we communicating and how are we making sure that all parents, families are supported and they all have the relevant information? Over 1/3 of those who gave birth during lockdown stated that care at birth was not as planned. Depending where they live, this varied from around 1 in 5 to 3 in 5 not receiving care as planned. And we're looking at West Midlands and the Southwest. And I think when we're looking at inequalities, and if we're particularly talking about inequalities, and this is a really important standard. Why is it that some hospitals have been able to maintain and keep certain services available and have been able to keep certain communication channels open and some haven't? And what areas are those hospitals situated in that are able to keep those services? And what are the demographics in those areas? And I think these are really important questions that we need to be looking at, and we need to be looking at those that have been able to, provide, planned birth for the parents, for the mothers. We need to be looking at best practice and seeing how we can then implement that within our own trusts. People in the lowest income bracket felt less equipped with the information they needed during and after their pregnancy compared with those in highest income brackets as well. So again, that discrepancy between different families dependent on their socioeconomic needs. I feel I've had little support from my epilepsy team during pregnancy. Pregnancy-related appointments for my epilepsy have been cancelled with no rescheduled date. Why couldn't this be done via phone? I feel very anxious about how much more dangerous it is for Black mothers at the moment, and lack of acknowledgement information around this for midwives and authorities. So the impact of COVID on care service and support in the postnatal period. So just 1 in 10 parents of under 2s have seen a health visitor face to face. And I just want to let that sink in. Now, we already know that before the pandemic, there was already the care, postnatal care was already kind of way below the standard that we expect. There's been lots of reports that are out there that have stated this. And it just seems like a lot of the structural inequalities that we're seeing right now are happening because those inequalities already existed, and postnatal has not been immune to that. 1 in 10 for a new mum. I think we can all, we understand the issues with face-to-face, but 1 in 10, that is having a drastic impact on new mums. Over half of respondents are breastfeeding, which has been seen as something that is really good, which is, any uptick in breastfeeding is a good thing. But over half of those that are using formula had not planned to do so. And I think it's all about choice. If you plan to bottle feed, that is fantastic. Yeah, I always say, fed is best, and it's all about the parent choosing the best feeding mechanism for themselves. However, we need to be looking at those that are choosing different options because they haven't been supported. We definitely need to be looking at how we can be supporting those parents better so that they have the choices available to them and they can make an informed decision that is best for them and their family. Just over a quarter of those breastfeeding, so they have not had the support they required. So that links into what I've just said. And digital health appointments left women feeling exposed and humiliated. Now, we talk about digital. Look at us right now having, Bradford Baby Week, which I must say, this has been amazing and really insightful. But we need to also add the humanity aspect into digital, and you'll see why in some of my next slides. So I'm just going to read this, and I'm just going to let this digest in regards to digital appointments and why we have to be so mindful. On day 6, my episiotomy stitches burst and became infected. The delivery suite told me to contact the community midwife, who told me to contact my GP. I was advised by the GP receptionist that I would have a telephone consultation with the GP, but I needed to provide photos of the wound and infection. This felt completely wrong, a complete invasion of my privacy, as I was being asked to send an email containing photos of my vagina and perineum to a generic GP practice email address to ensure I could receive antibiotics for the infection. I'll just let that digest. Difficulties with breastfeeding 1-month twins. Difficult for me, but they will still be fed. However, if we have to resort to using formula as a result of a lack of breastfeeding support, then this could well affect their future health. Formula is not a substitute for breastfeeding, and there's no reason why breastfeeding can't work with proper support. So this was a mum that wanted to breastfeed, and that's why you can see why she's so passionate about that. But she just felt that due to a lockdown, she just was not getting the support to breastfeed her twins, and she felt really frustrated because of that. So key findings from the Babies in Lockdown report. COVID-19 has affected parents, babies, and the services that support them in diverse ways. And we know that there's inequalities dependent on where you live in the UK. Families already at a risk of poorer outcomes have suffered the most, and the pandemic will cast a long shadow from time to come. So the free policy ask that we're asking is a one-off baby boost to enable local services to support families who have had a baby during or close to lockdown, a new parent infant premium, providing new funding for local commissioners, targeted improving outcomes for the most vulnerable children, and a significant and sustained investment in core funding to support families from conception to age 2 and beyond, including in statutory services, charities, and in community groups. So ways that Best Beginnings can support. So we have our Baby Buddy app, and I'll quickly go through that. And we also have a project that we're currently running now, which is funded by the Department for Education and is in collaboration with Bernardo's, which is the See Hear Respond project. So Baby Buddy is a purposeful digital health intervention, which has been designed to empower parents and parents-to-be. It's to support relationships, it's to enhance conversations. And especially when we're looking at this season right now, the season that we're all living in, we need to make sure that parents, as you can see, and families and so forth, are having, correct information to be able to augment and support the work that you're already doing with them in the communities. Proportionate universalism in action. It's free and advert free, reading age of 9, representative, inclusive, and it's about show how and not tell to. And the reading age of 9, the reason that we have that is because, as we've heard, throughout this presentation, English is not necessarily everybody's first language. So we wanted to make sure that we're using, simple terms so that all parents can access this tool. I'm not going to go through these stats, but just reaffirm that it's easy to use and easy to understand, and what parents are thinking of that. Again, these are some of the feedback in regards to how useful parents, and I must add, parents from all different backgrounds, and I think that's the beauty of the Baby Buddy app. Again, here, if we can just look here, we have a 24/7 confidential crisis text messenger. So, get help, that's an immediate tech support. So if it's 2 o'clock in the morning and you've got a new mum or a parent who's feeling really, really anxious and she feels that she needs to speak to somebody, we have that tool there to be able to support them. And again, here, if we look at this slide, daily information supporting well-being, which is so important, right now. It's always important when you're pregnant, but I think now more than ever, it's so important. And I hope that you can see the avatars there as well. Unlike other apps, you can make the avatars look like you. A lot of the times, there's a barrier to accessing information because you feel that tool is not for you. You feel that it's been designed for others in mind, whereas the benefit about Baby Buddy is it's designed for all, and you can make it look and feel like yourself and your community. This is where you can, Baby Buddy is available. It's been endorsed by, and you can download it in any of the app stores. And I'll See Here Respond, and I'll just quickly mention this. So at the moment, we're offering free group support, and it's basically a support that stimulates or simulates the kind of support that you would normally get face-to-face, but due to COVID, we can't have that now. And so it's a group support that is led by expert midwives and antenatal specialists. It's peer-to-peer support, and you can, if you just go onto our website, bestbeginnings.org.uk, it's See Here Respond. But even if you just go onto our main homepage, if you don't have that information, you can sign up, or if there's any women that you're supporting, you can also refer them there and sign up. Thank you.
Thank you so much, Agnes. That was really, really good, and very much what we've been picking up from our parents that we work with in Better Start Bradford. It's just so important that we're able to get support to those parents, and that's absolutely our purpose. And just a couple of the things that you mentioned, lack of postnatal support, we absolutely picked that up when we were designing our programme, and we've got quite a lot, but it's all had to be virtual during the lockdown, and so lots of parents haven't had that one-to-one support that they really need, and they really feel is missing. But all credit to our projects. They've all tried really hard to make sure they continue to keep in touch with the projects. Alia, who's here from the doula project, but as chair of the Maternity Voices Partnership, the doula project have made sure that they've kept in touch with women and offered their service to women throughout the lockdown. And I know from the feedback that there's been that's really been appreciated. But it just isn't the same as being able to be in hospital with somebody and holding their hand. And so, you know, we can't wait until we can get back to that. I am worried and agree, but it's worrying that you say it will cast a long shadow. I think that's true. And I think that's something that we are already thinking about how we can address that. So I'll just talk a little bit about Better Start Bradford and you know, where we feel that we fit into the picture of support for parents and what our thinking is about the future. I'll try and be brief because I think it would be really good to have as much time as possible for the panel discussion. So thanks so much to all the people who've spoken so far and to the people who've come to the panel, and really looking forward to that discussion. So this is Exploring Inequalities in Maternal Healthcare, and I'm the head of programme here at Better Start Bradford. And I was actually going to use a photograph of my new grandson because I'm so proud of him and it's such an exciting time. But I actually chose to use this picture because this is one of the babies who was taking part in Baby Week last year. And it's what we're missing this year. We've had such a good Baby Week. It's been, everybody's risen to the challenge. But it was so lovely to be able to have these interactions with babies last year and for seeing them having such good fun with our Baby Week activities. So we're really looking forward to being able to do that again next year. But, you know, very grateful to all the people who've done things this year that have been great and have been good fun. Right, so what is Better Start Bradford? Well, it's a 49 million pounds National Lottery partnership led by our parent organisation, Bradford Trident, for a 10-year programme, and we're currently halfway through year 5. So we're halfway through year 6. We were going to celebrate having done 5 years all the way through this year, but unfortunately COVID put a stop to some of those celebrations. But you can see we are still recognising that we've done 5 years and it's worthy of celebration. The programme's a test and learn programme, and the idea is that we learn from what we do, and it's used as a model for reform across the district. I'll say a bit more about that in a minute. And it's based on the best available evidence and science and adding to the evidence base of what works in improving maternal child health. Our main programme outcomes are social emotional development, communication and language, and food and nutrition, with a specific focus on preventing obesity. And it's entirely focused on pregnant women and young children aged 0 to 3, because that's seen as a window of opportunity in which you can change a child's future. So we all know that those early years are the most important years, but the programme is focused entirely on those years. And the aim for us in Bradford is to reduce the inequalities and outcomes, which I'll talk about in a minute. Our programme in Bradford is a partnership of community and system leaders. So we've got our partnership board and various governance structures, which include representation of the community and primarily parents of children aged 0 to 3. And we have 20 projects in our portfolio of interventions. So these are the people who we're working with. These are the people who make up our families in the Better Start Bradford area. And just recognising our evaluation partner is born in Bradford. And they do our evaluation through the Better Start Bradford Innovation Hub. And this is their information. So you can see our population is primarily Pakistani origin. And that's first, second and third generation Pakistani families. And then there's a range of others. The white British families are 25% of the population, but less than that for the pregnant population, less than that for the percentage of children that are born. The Black African and Black Caribbean population is quite small in our area, but is a significant presence and has a long-standing presence in our area in Bradford district. What life's like for our families. So when we put our bid forward to the National Lottery Community Fund for the bid, we had to talk about what the needs were, and this is highlighting what some of the needs are. So in our 3 wards that we're based in, we've got some of the highest levels of poverty and deprivation in the country. There's quite high levels of poor housing. It's primarily owner occupied, but there's lots of terrace housing. There's things called back-to-backs, which those of you who aren't from Bradford probably don't know what I'm talking about. But there's a lot of back-to-back houses and poor quality. There's some old council housing as well. It's poor quality, but there's some older council housing, some of which is being improved, but some of which is still quite poor quality. It's got, in Bradford, we have some of the highest levels of infant mortality in the country, and in our area, we've got the highest levels of infant mortality in the district. And when Chloe spoke, she said that the numbers were small, but the numbers are still highly significant. And this has been persistent. The Born in Bradford was set up as a response to an infant mortality commission, which is now 15 years ago in Bradford, and we're still challenged by those figures. Our area suffers from poor air quality, and we know a lot more now about the impact of that on children's development. We've got some of the highest levels of childhood obesity in the district, and as we know, intervening early, getting in early and preventing that is the best way to tackle it. And we know that perinatal mental health is an issue, because we have a birth cohort, BIBS cohort, which our mothers report low mood, and that's higher than is picked up by health services. And so we are really keen that we're addressing that. And our program's aimed at improving children's school readiness. But what we know is that the good level of development that's measured when children start school the scores are lower in our area. So what are we doing? What are our projects that are aimed at pregnancy and early childhood perinatal projects? We have a personalised midwifery project, which we're just moving on to its third phase, and that is a continuity of care project. So the families who receive that get the same midwife throughout their antenatal, through birth and through their postnatal care. I just arrived. Some of these projects have been affected by COVID, but we're absolutely committed to them, and we're just, like I said, just about to start phase 3 of our personalised midwifery project. And there will be a specific work stream in that, in addressing inequalities, in specific in the inner city area. Bradford Doula Project, that we've got Alia here on our panel, and they're providing support for parents perinatally, so in the run up to the birth, often at the birth and postnatally. Really important for some of our families, and particularly if you look at the issues of perinatal mental health and how much that support can affect that. We have an infant mental health project, Little Minds Matter. It's an innovative project, and it's supporting those families where there are infant mental health problems, and you know, that affects the relationship. So the relationship between the parent and the child can cause issues for the babies. It's only been going a couple of years, but it's made an enormous mark already, and once again it's been extended into the inner city area to provide support to families who are less well supported by the existing systems. Baby Steps is an antenatal and postnatal offer, which includes group work and one-to-one work developed by the NSPCC for vulnerable families. Very successful and very popular. We developed, as part of our offer, ESOL for Pregnancy with Shipley College, who had developed it them previously in conjunction with the NHS. And the purpose of ESOL for Pregnancy is to work with women whose English needs ESOL support, but particularly to help them to be more active and more involved and more knowledgeable about their care in pregnancy and birth. So to try to help them have a voice, to increase their ability to understand and have a voice in what's going on, and support them during pregnancy. And of course, one of the benefits of a group like that is that the women in the group support each other. So it immediately provides an answer to some of the isolation issues. Home Start has already been mentioned. This is to support parents who are struggling to cope in the early years, and it's a national well-known service. It's very effective in our area. We've got the perinatal support service provided by Family Action, which supports parents who've got mild to moderate mental health problems in their experience of pregnancy and childbirth in early years, and we've got breastfeeding support. So we have a service which actually provides in-home one-to-one support for parents who need support with breastfeeding. As I said, all of these projects have continued during COVID, but most of them have had to work in a virtual way, obviously apart from the midwifery project. So what are the gaps? What are the things that we know we're not doing so well, or why we're not? So credit to Innovation Hub, this is their slide, but we know that we need to think more about mums that can't speak English and how we get support to them. We know that we need to be able to get our messages across about early lifestyle behaviours. And whilst this is not about lifestyles, our session today, it is about how our services support people, and that's how we get those messages across. It's providing that support. It isn't about, we need to understand that one size doesn't fit all. How do we engage all our communities? How do we make sure they're involved and they've got a voice in what we're doing? And we can't allow the barriers that people experience to increase the inequalities that our service is set to address. So if what we're providing is more available, so there's people who are better equipped to access it, then that will increase rather than reduce the gap. And we have to understand that and be aware of that. We need to support how things happen in the home and to support parents in being able to support their children themselves. And we mustn't forget about dads, we've already mentioned that, but they're so important to these early years. And I was really interested in what Rizvana said, because there are all sorts of myths around that we need to tackle. But our experience of working with dads is they're all really keen to be involved and feel excluded and feel that they're not addressed, their needs aren't addressed, and their involvement and their contribution isn't properly recognised. And finally, what else are we going to do? So I talked about our key outcomes, but our fourth outcome is including system change. It's always been there. And so here's some of the things that we're thinking about is we're here to try to redirect investment to prevention and early intervention. We're here to try and create systems with our partners that work for parents and to build that focus on the first 1,000 days that's so important. We're here to help to make sure that evidence is used and evaluation is effective in planning of our services, so that we're doing the right thing in the right way with the right people. And we want to create a sustainable change, so we want to do things that will be here once we've gone. We absolutely want to use co-production, bringing parents and community voices into the decision making and to the planning and the design of what happens. And also the children's voices. So there's various ways we can do that, but listening to children in terms of the services that they receive is really important. We need to develop practitioner skills and understanding so that they both understand what our program's about, but also they're skilled in addressing those inequalities and challenging themselves in terms of their practice, and so are able to change their practice. But making sure they're given support and the capacity to do that, we mustn't underestimate the challenge in our services from the pressure that they're under. And most importantly, addressing inequalities in services and in outcomes so that our work improves the prospects for all of our children and not just for some of them. So that's me. Thank you very much for listening. And if anybody's got any questions, I'm very happy to answer those on the panel.